Our next speaker is, continuing on in his theme, is Carol Noina Nyirenda from Zambia, Carol's a public health advocate, as you will hear, an international speaker and trainer from Lusaka. She's Executive Director of the Community Initiative for Tuberculosis, HIV/AIDS and Malaria. She's National Coordinator for the Coalition of Zambian Women Living with HIV. And she's been a board member representing PLHIV and those affected by TB malaria on the Global Fund Board, UnitAid and the Stop TB Partnership, and is still on the International Union Against TB and Lung Diseases. At the regional level, Carol is President of the Africa Coalition on Tuberculosis and recently elected Chairperson of the Pan-African Positives Women's Coalition. Please welcome Carol. Thank you.
Thank you. Thank you, everybody, and thank you for coming. So people aged 50 and over are a growing part of the HIV epidemic, and this requires new responses. Many people with HIV, we are now living longer, we're having more active lives, and this is thank you to the expansion of effective antiretrovirals. The HIV response therefore needs to account for this important demographic by reflecting risks and trends and providing appropriate prevention, testing and treatment services. HIV services for people aged 50 and over would be helpful if they're integrated with non-communicable diseases, screening and treatment, as well as other age-appropriate services. So I thought I should share a bit of statistics that I got from one of the UNAIDS reports. Worldwide, an estimated 3.6 million people aged 50 and older are living with HIV. For the first time since the start of the HIV epidemic, 10% of the adult population living with HIV are in low and middle-income countries, and these are aged over 50 and above. I was saying, if we look at those people who were about 20 when HIV was discovered, or with about over 20, they are in their 50s and their 60s now. In 2012, there were an estimated 2.9 million people aged 50 years and over living with HIV in low and middle-income countries. In high-income countries, approximately 30% of all adults living with HIV are aged 50 and over. The proportion of adults living with HIV that is aged 50 years and older has increased in regions at varying rates since 2007. So what are the factors? Why is the number increasing? Like I said when I started, really one of the factors is the antiretroviral therapy. It's prolonging our lives. I'm sure most of people out there know that in the early years when you were told you were HIV positive before we had the ARVs, it was a life sentence, a death sentence. All you did was go back home and wait to die. But because of the antiretroviral, we are living longer now. And then for me, I think we are talking about the decreasing HIV incidence among younger adults, shifting the disease burden to the older people. I'm thinking it's also the fact we're looking at the social media. The younger generation has more access to information than, for example, in my case, I always say, if I had information earlier, I don't think I'd have gone through the stress I went through when I was sick. And there's the often unmeasured and thus often overlooked fact that people aged 50 years and older exhibit many of the risk behaviors also found among younger people. I don't know why people think when you're over 40, you stop having sex. I don't know why people think that you stop doing all the things that you're doing when you're young. We are still normal people like everybody else. So in most cases, this is ignored, while whatever the young people are doing, maybe actually even do it more. So this is an area that is being ignored. So I thought before I go further, I should sort of share a little bit about my life journey. So I'm 50 years old now. I turned 50 last year. And I found out my HIV status in 2002. Unfortunately for me, I had tuberculosis before I even knew I had HIV. It even made it very difficult for them to diagnose the TB because I didn't know my HIV status. As most of us here know, when you're HIV positive, what you have is what we call extrapulmonary TB, which is a TB which is not in your lungs. So I did not have sputum, I had a very dry cough, so it was difficult for them to diagnose. I had to go through over 4-5 x-rays in a period of 6 months. And my husband died in 2001. And again, I think it's this issue that I'll talk about later of especially the men not wanting to go for testing and finding out what it was. I suspected, but when I asked him if what he had was HIV, we should go for testing, he refused. He said we're just having financial problems at that time and it wasn't HIV. And for me, because I had been faithful, I'd been married for 14 years, I had not strayed from my marital bed, I didn't worry about it. And then after my husband died, like I said, I had TB, then I had herpes zoster, so I had all these, the S in the AIDS at the end for me was really happening to me. I was a playing field for the syndrome. So I had Kaposi sarcoma. This is a cancer that affects you, that is an HIV-related cancer. So I had to deal with all these diseases at the same time and also deal with the loss of my husband. And I underwent chemotherapy to take care of the cancer, which is in remission now. I'm lucky I haven't had problems for the last 7 years. And then fortunately in Zambia, we had the free rollout of antiretrovirals. When I started in 2002, I had to use my own money. I ran out of money. My family helped me. The church helped me. After a while, after 6 months, there was no money. So my family and I just sat back and waited for me to die. Fortunately, in 2004, there was a free rollout of antiretrovirals to Zambia. And I was one of those people who were lucky to be able to access the free antiretrovirals. And from that, I joined a support group and I started learning on how to live positively. I went also to the computer. I got into the computer age and learned a lot about HIV, trying to understand how I could live longer, how I could live better, and what this so-called HIV is and how I can deal with it in my body. Because when my husband died, he left me with 2 children. My daughter was 9, my son was 12 then. So after that, I thought in helping other people, I decided to sort of set up an NGO, and this is a patient-led NGO, the Community Initiative for TB, HIV, and Malaria, CETAM Plus in short. We have people living with HIV and those affected by TB. Because we thought we are the ones who understand the issues, what we do is we do a lot of advocacy and also complement the government efforts. We do advocacy at national level as well as community level. And from then, I decided to also get involved at international level to make sure that I'm also around the table where decisions around my life, which is antiretrovirals, the medicines, I should find a space around the table. So I managed to join the Global Fund Board as a board member representing affected communities and other global health initiatives. So my last CD4 count, my last CD4 count was 1,240. I am doing well, but what I've noticed is that I get tired very easily. In the earlier days, for those who knew me, I was a very strong advocate. I'd be running around with everybody with these activities that were there. But I'm sure most of you have seen that this year I haven't been in the forefront. I'm getting tired. At 50, things are changing. I keep having anxiety attacks, and then I've reached menopause, so now you think, is it menopause? Is it HIV? Is it the antiretrovirals? So that's a question that would like the researchers to answer for us. So HIV prevention services and other services such as tuberculosis screening need to place increased emphasis on people over 50 years and older and their specific realities and needs. For those who work around TB like myself, we know TB is the main killer of people living with HIV and AIDS, which is what I keep telling people to say. When I go to AIDS conferences, I get surprised that people are not panicking. No one is really talking about TB. TB is killing us. I've been in treatment for close to 10 years, and I could have TB, and within a week, I'll die, which means the investment for 10 years that was put in me is just going to go to waste. So it is important that we put more emphasis on TB. And unfortunately, people who are 50 years and above appear to be at a greater risk of TB. There are also indications that people 50 years and older may know less about HIV compared to younger people, especially among women. When you look at somebody like me who comes from Zambia and some of my colleagues from the rural part of Zambia, where are they going to find the information? What time are they going to go and get water or collect firewood and get information on HIV? Which is why I was saying it's easier for younger generations who can go to social media and get information. And for women, especially for women, it really gets worse because of the biological changes that can also put sexually active women aged 50 and older at higher risk of acquiring HIV. As you get older, the thinning of the vaginal wall after menopause increases the chances of lesions and tears, thereby increasing the risk of HIV transmission during sex. One of the areas where we're working really hard as a coalition of Zambian women living with HIV and AIDS and Pan-African Positive Women Coalition is around areas around menopause. I have women from my area who stopped taking their medication because they thought it made them stop having their periods. It made them start having hot flashes. Most of these women don't even know anything about menopause. So there's menopause, there's HIV. You only get menopause when you're aging over 50 or some people much earlier. And then there's the issue of lipodystrophy. This is a redistribution of fat. At a younger age, you have a nice body, the pear-shaped, so you have some flesh down there. As you take this medication, after a while, all the flesh goes up here. You start looking like somebody who lifts weight. You have, your hands become really small and tiny. You just change. All of a sudden, your shape is changing and you're turning into some kind of, the pictures that we see of aliens, I've seen some of my colleagues look like that. This is a side effect, like David said, of some of the medication that we take. So for services, people living with HIV age 50 and over tend to recover more slowly compared with the younger ones. So generally, even when you're much older without HIV, you recover slowly. So with HIV, with the immune deficiency and the antiretrovirals, it's even worse. And usually less likely to take the HIV test compared to persons under 50. We're also likely to be diagnosed late in the course of HIV infection after our health has deteriorated considerably. For example, in my case, I did not go for a test. Like I said, for me, it's because I thought I was safe. Because I could not take the pill with my husband, my gynecologist advised me to use the condom. But in our early days, the word consistently and correctly were not there. So on his birthday, we didn't use the condom. Christmas, we didn't use the condom. I didn't know that would put me in problems. So it was different then. So by the time they found out my status, for me, it was a time when I had fully blown AIDS, really at the end of the tail line. So in most cases, we don't go early. When you're 50, there's so much to do. You're busy and other priorities. And more than 1 in 10 people initiating antiretrovirals, as the research says, therapy were age 50 or more, and about 2/3 were women. This was from research. And HIV treatment can be challenging if a person living with HIV is also experiencing chronic conditions. What has been found out is in most cases is heart attacks, bone fractures, kidney disease, or other cancers. For example, like I said, I had a cancer called Kaposi sarcoma. In Zambia, the country I come from, we are number 1 in Africa for cervical cancer and number 2 in the world. And unfortunately, for women living with HIV and AIDS, we have 85% susceptible to cervical cancer. So other conditions also make it worse. Unfortunately, it was noted that in older people living with HIV and AIDS, this condition may actually worsen their HIV disease progression. And though most of us living with HIV, the older people, because we have children, we have families, we are likely to adhere more than our younger counterparts, the chronic conditions, the other diseases usually affect that because of the pill burden. You have to take so many drugs. The other big area that I want to talk about is the stigma. And I want to talk about the stigma around the individual, group, and system level. At individual level, you can imagine somebody who's 60 or 70 or 80 taking their antiretrovirals. You have your in-laws coming, you have colleagues coming. Because of that age, some people feel bad and they'll not take their shot, they'll not take their medication. When it comes to group and congregate settings, churches sometimes will discriminate against these people. In the villages or communities, people will laugh at them to say, at your age, how can you have HIV? I went to a school where I was giving a talk where when we opened up for questions, this young boy went up to the podium, to the mic and said, you are so old, so you're a prostitute. Yeah, but how can you have HIV at this age? Are you a prostitute? Do you get business at your age? So there's that kind of stigma. So for people who cannot deal with that kind of stigma, they'll stop taking medication. I know colleagues who have actually stopped going to the clinic because of that. When it comes to health workers, those ones can also be worse. One colleague, again, went to the clinic where she found a 20-year-old clinical officer. And because of the words that he said to her, she stopped going to get her medication. She says, I cannot be going to, to a clinic where young children who are young enough to be my grandchildren are saying such things to me. Let's talk about people who are open about their status. People like me, I'm open about my status. I decided to be open so that I can help other people. But I'm discriminated against. I'm still single now because no one wants to go out with me because I'm open about my status. I tell people I'm safer because I've told you my HIV status than you going out with somebody who doesn't, you don't even know their status. But still no one will go out with me because if you're with me, then everybody knows you also got HIV. But I'm okay with it. In conclusion, I wanted to say HIV/AIDS is not a disease of the young. In many cases, you think it's only young people who get HIV. Like I said, we are at 50, 60, we still have sex and whatever other vices, so we can get HIV. And it will be old, even the younger people will be old at some point, and which means the number will keep growing. And we are also asking for more studies. And as these studies are being done, we want those studies to be available, to be accessible to us. For example, the first presenter, I've listened to a lot of what was said. It's the first time I'm hearing all those results. So it would be helpful if we can have that data and we access that information and are able to use it. And then the services needs to be put in place to accommodate the specific needs to ensure dignity. It's not everybody who is as strong as me to stand up and talk about your status. Because for me, I will not allow anyone to stigmatize me. I always tell people, once I've told you my HIV status, I take the power away from you to stigmatize me. Like I said, I was faithful, but I got HIV. I will not allow anyone to sit on me and stigmatize me. But there are people out there, there are colleagues, there are people who actually hide in their homes because they have HIV. So we need to have services that can help the elderly to be able to access medication freely, where maybe even the providers there are of the same age. And then we need tailored messages. If you're going to give me a message on the YouTubes, all these social media, I'm trying. My children do it for me. I find it really hard. I'm not going to go to all those things and access the information. Tailor the messages and use the messenger that a person of my age is going to use. And targeted outreach. Like I said, most of these people and their communities, most of these people are hiding in their homes. Find a way of outreaching to get to them and get the information to them. The support systems, like David said, the pill burden is one of the hardest parts of our lives. There are times for me, I have a support system of my children, my colleagues, and people that we work with. When you've taken your medicine for a long time, like for me for over 10 years, you get really, really tired. For me, because I had cancer, I had to take what they call first line, 2 levels of first line and 1 from the third line. So which means I take 6 pills in a day, 3 in the morning and 3 in the evening. I admire my friends who are now taking 1 per day. So after a while, you really get tired when you're busy. So there are times when I just tell my children, I really don't want to take this medication anymore. So what my children will do is they will let my friends, they will let my mother, they will let everybody. So every time everybody's calling me to ensure that I take my medication. Everybody who sits around me sits with me and helps me. So I'm lucky to have that kind of system. You don't have things like support groups of elderly people living with HIV and AIDS. It's very difficult for them to come to a support group where there are younger people. So if we can have systems that will help people, that will be helpful. But whether we like it or not, it is changing. Even the young people who are here now will get older and systems need to change to accommodate them. Thank you.
Thank you very much, Carol.